coming to you live from my house with a very strong nail polish smell because my daughter decided to do nail polish down here. But I did want to take the time to go over a brief annotated version of the National Registry prep class I did for my class the other day. So if you are my current students, you've already done this. You don't have to listen to this video. Unless you're just bored driving to a clinical or something like that, then hey, go for it. So tis the season for National Registry prep. I'm a big fan of National Registry. I like having a third party vendor that has no ties to any local practice like states or anything like that. I like the fact that everybody in Hawaii and Alaska has to pass the same registry and test as people in Tennessee, Florida, New York, and all that. I like that. I like for people to be tested. I think it's good to have, like, I would like my surgeon to know what he's doing. I'd like to know he passed some sort of board test. And I get the whole thing, like, just because you pass the test doesn't mean nothing. No, you're right. There's a lot of really good providers that would be phenomenal providers. They just suck at taking tests. And so I live in that world of people who suck at taking tests because I teach EMT, and a lot of times this is the first time people get organized or into a hierarchy where they have to demonstrate medical level of knowledge, and that's a completely different subset of skills. So with that being said, figured we'd go over some of the issues that we've had with registry, that I've seen with registry. Let me move my little guy around a little bit more. So I took this from a Facebook group I'm on. If this is you, I apologize, but I did black out your name and all that stuff. And it's a real screenshot. I see these almost every day, if not every few hours, and it's people who are just frantic trying to pass the registry, and you're like, what app can I do? What thing can I do? And I'm sure instructors are out there. They're also, kind of pleading for you to do the right thing when it comes to studying and preparing and stuff for it. The National Registry is no joke. You can read this comment yourself. There's many like it, and I hate hearing it. I like the National Registry, but I don't want them making any more money than they need to. So I want people to go in there, take it the first time, pay that money up front, and then be done with it. I don't want National Registry to get 2 or 3 attempts. I don't want you to have to go through a refresher and do another 2 or 3 attempts. I don't like any of that stuff. I want people to go through and kill it on the first attempt. So one of the things that you can do when you're getting ready to practice the National Registry and stuff is there's this concept where I think there's a lot of spraying and praying, whatever it is. Basically, I'm just going to study everything and hope that I'm studying the right thing. And that strategy probably worked out quite a bit in most EMT, advanced EMT, and paramedic programs where you just study pretty much everything, and then that test and then on the test, you'll get tested along an entire continuum. So 60 to 70% of what you actually studied might be on the test. That might be enough to get you passing. However, when it comes to the National Registry, you may get 5, 10 questions on ICP or hypertension or something like that, or breathing problems. You're like, man, they're really hitting hard with breathing. And so it goes from you're just really hoping that you can swap out the random stuff that you studied with the National Registry and hope that's going to be enough. So I figured today would be a good opportunity to shine some light on how the National Registry works and how to take the test. This isn't all inclusive. I'll upload some more videos and some more help. If you subscribe, I hate saying it because I'm not one of those. I hate even the thought of influencer type mentality, but that's the only way to get notifications that I post free stuff for you guys. This is an AMT textbook. It's the only one. It's the only picture I had that I could do at the time. And I found out on Keynote you can make transparent backgrounds. So I put that to good use, making a typical 90s bedroom. So for some of you older people like me, you probably recognize a lot of that stuff. If you're younger, like most of my class, they didn't recognize hardly any of that stuff. Did anybody see the White Ranger? He's right there. Cool. Okay, so let's shed some light on how on the National Registry. So also found an animation thing that I like. The first thing we'll go over is Bloom's taxonomy. You don't really need to go into too much depth about Bloom's taxonomy, but I do think it's helpful to know what it is. I did a post this past week or so talking about Sun Tzu's Art of War. You need to know your enemy. This is a part of knowing your enemy, is how the test items are created. So along the continuum and along the hierarchy of Bloom's taxonomy, test items are created. You start at the very bottom, which is just, can you remember stuff? Do you understand what you remembered? Then it goes to apply it to a critical situation, analyze a critical situation. Then you can evaluate a critical situation, and then you can create a treatment plan or create options based off of all the below in order to bring about the best option and the best treatment for your patient. I tend to not use the entire Bloom's taxonomy. I take the bottom two and call it level one, the middle two call it level two, and the top two and call it level three. I did that for my master's, and my professors didn't seem to have a problem with it when I was doing in education. So that's kind of the way I do it. I go levels 1, 2, and 3, 3 being kind of the most challenging because it requires you to know levels 1 and 2 before you can even go on to level 3. So if you're studying and you don't even know like what cardiomyopathy is, left ventricular hypertrophy, CPAP, PEEP, PIP, if you don't know what any of those acronyms even are, if you can't spell them out, then you don't remember those. That means you don't even have the baseline. If you understand it, like if you know positive end expiratory pressure helps with alveolar recruitment, it's most time it's given in centimeters of water pressure, cm H2O, then you understand, then you can learn how to apply it. CPAP is really good for patients in congestive heart failure. So then you can analyze a patient's condition. They're giving you with shortness of breath, dyspnea, chest pain, crackles, something like that. And you're like, oh, I can now use CPAP for this patient. You can evaluate the options that you have in front of you. Like, what should you do for this patient? Should you give them aspirin, nitroglycerin, CPAP? They'll give you all sorts of weird responses, and they'll have one or two right ones, and you have to be able to evaluate all of the options you have in front of you and do the one that's going to be the most beneficial for the patient and the one that does the least or no harm. That's the two things you need to take away from anything when it comes to the National Registry is what's going to be the most beneficial for the patient and what's going to do the least amount of harm or no harm at all, preferably. And then, of course, is combining everything to create a treatment plan for them that makes the most sense. So I have some practice items. I'm going to go through them slam bam. So if you want to pause so that you can get the answer yourself, that's fine. I think I'm going to have a separate blog post, which is just going to have these pictures on there. So, and then I'll have the answers here in this podcast, but you can just, or this video, you can do it yourself. So what is the correct compression to ventilation ratio for an adult with one rescue? I put a 1 at the top right because I wanted you to know this is a single level. You should just know this. You should know that it's going to be 30 to 2. All the other ones don't make sense. All the other ones are not correct in any way. And if you get this, you're like, oh, I know that. Good. You're at level 1. This is another level 1 question. You're on scene with an unresponsive adult who fell from a roof. Here's his vitals, 190/110, pulse 52, respiratory 24. What's the most likely cause of the patient's blood pressure? You can make the argument that this is kind of a level 2-ish question, but I feel like it goes back to understanding and remembering what increased cranial pressure is. So I put it as a level 1, and that's exactly what the answer is that blood pressure is due to increased cranial pressure. So when you're going through your test items, don't overcomplicate things. Overthinking is like the major problem with students. Like they will overthink. They will find a reason why every single other option could be the right answer, and it sabotages them. It's like, no, dude, the A is the only one that makes the most sense. Decreased pressure on the brainstem. No, heck, that would actually do the exact opposite. Cardiac tamponade. Not in this specific situation because of the pulse. Like you could say, because cardiac tamponade is actually, I put that option on there because I was like, that's a really good one. But if you look at it in light of the pulse, so you did have to kind of know a little bit more. So maybe it should have been a level 2. I'm not perfect. Should be the last one. Which of the following would lead you to believe a patient has an upper airway obstruction? Choose all that apply. This appeared on the registry a few years ago. Choose all that apply. So you get more than one option. Instructors and students all hate it, but it's in alignment with exams for like nursing and medical school, stuff like that. So all you're going to do is go through your upper airway obstructions. So wheezing is completely out. It would be stridor, gurgling, no rhonchi because that's something that you're going to hear in the lower airways. Crackles are going to be in the lungs anyways. The only one that I was like, I could justify grunting in infants if you can make a good argument for it. I would think that the registry would not put something like this on there because technically grunting in infants is an indication of a respiratory decline, and that could be something like RSV, could be pneumonia, some type of upper respiratory or lower respiratory. And it's their way to keep their airway open. So it technically could be an upper airway obstruction. It's like Schrodinger's cat. It could and couldn't be at the same time. Don't send me hate mail about that. But I told students like, if you put D, great. If you didn't, that's okay too, as long as you could justify why you put it in. I like to at least make the challenge there, because even if it's bottom level, like level 1, you can still have a challenging question for understanding content. So when you got done with those questions, hopefully you're here and you're feeling pretty good about yourself. You're like, all right, I kind of understand those. I recalled some facts. I understood what those facts meant. So now we can go into like, these are level 2 type questions. You got a 22-year-old unconscious trauma victim who has snoring respirations. What's your first intervention? And I used to tell students, cover up the answers and come up with your own. I don't do that anymore. I tell them, hey, read the question and then go through each answer item and plug it back in and say which one makes the most sense for the patient. So I said, what's your first intervention? So what's the first thing you're going to do? Insert an NPA. So there's this scene in The Dark Knight where the Joker, Heath Ledger's character, goes into this group of gangs, this group of guys, and there's like, hey, there's only room on my squad for one. He snaps a pool stick in half and then hands it to him. So I always liked that scene. I always liked that movie, The Dark Knight. Thought it was one of the best Batman movies ever. And what I'd like to do is I tell students, hey, give one a pool stick and make them fight it out. So insert an NPA, I don't know if it'd be my first thing, but I do like it. So I'm at least going to, because pretty much everyone's good with that. I like it. B, place an OPA. That's not the first thing that I would do, because we have no idea about their gag reflex, all that stuff. C, ventilate with a child-sized BVM. That's a weird one. I'm not going to think about that one. D, adjust the airway with the jaw thrust maneuver. Oh, yeah, that's definitely getting a pull stick. E, administer naloxone. F, check the patient's glucose level. I mean, you might do all of those. That's the thing. But it's like, what's your first one? Well, you should get between A and D, and really the first thing you're going to do is open an airway, and you're going to have to use a jaw thrust maneuver. So D is going to be the best answer. And again, you may be going through this going, oh, wow, that's really easy. If that's the case, good. Then you're thinking correctly. All right, here's another one. 5-year-old, respiratory distress, inspiratory stridor, and drooling. What should you do? This one I think is going to be challenging. So place a face mask with supplemental oxygen. Okay, I like that. We like to give kids oxygen. I'm trying to give him too much, but if he's in respiratory distress, absolutely. So let's think about that. Boom. B, suction the patient's airway. Unless it has the words gurgling or something really more to indicate that there is an airway obstruction, we ain't messing with airways like that. C, attempt airway visualization with a pen light. That's actually not a bad answer. Except we don't like to look in airways that have inspiratory stridor, because even if he does have something in there, we're really not going to be inspecting their airway with a pen light, making a matter and possibly forcing this potential foreign body airway obstruction into their airway. D, consider blow by oxygen. That's another one that I would consider. E, lay him supine and open the airway. No. So it should be between A and D. Now, if you're like, it's going to be A, it's A because of the oxygen and the face mask. Well, I don't like that answer because of the drooling, because now you have an airway obstruction potentially. You don't want to have aspiration. So really considering blow by oxygen is going to be the best bet that will do the least amount of harm and provide the most benefit for the patient. Here's the last one for this one. During CPR in an adult, the AD advised no shock. What should you do next? Check for pulse, ventilate, resume compressions, reassess patient's airway. Honestly, this should have been a level 1 question now that I'm really reading it out loud to myself, because as soon as it says no shock advised, unless the AED specifically tells you to do something else, the automatic thing should be to resume compressions. That's AHA standards and guidelines, at least for right now. Oh, I'm sorry, I had one more. An unconscious trauma victim is breathing with loud snoring. What is your immediate next action? Again, perform a jaw thrust, insert an NPA, suction the airway, apply high flow oxygen. So the best one is going to be opening the airway with a jaw thrust maneuver. I should have probably put some more medical type questions on there instead of trauma and airway. So at this point, you're going from here to here. And if you got through those, you're like, man, those were a little bit harder. Then that makes a little bit more sense, because the Bloom's taxonomy level, it's going a little bit harder. It's requiring you to think a little bit deeper. Now we'll get to the third level. And we'll see if you guys think they're actually third level. I don't know. So COPD patient, diminished breath sound, cyanosis, increasingly agitated. SpO2 is 82%, 2 liters. What's the most appropriate next step? So This actually kind of had my class tore up a little bit in both sides. They were between A, somebody put D, B. There's no indication that there's anything in the upper airway that requires suctioning. So you have A and C should be between those two. I understand where people say, hey, increase it to 6 liters per minute. Here's the issue. Look at that first part, diminished breath sounds. You're going to assist ventilations. Like, they're becoming increasingly agitated or whatever. Yeah, but you got to increase their tidal volume. And I know that's a weird situation because you're like, well, you wouldn't bag somebody who's breathing. It's like, yeah, actually you can. You can assist their ventilations. You can absolutely assist their ventilations. It's an entirely appropriate thing to do. They may not like being assisted with those ventilations. So as they're breathing in, you're just kind of squeezing the bag and letting their lungs open up just a little bit more. That's infinitely better than just putting them on 6 liters per minute, because if they have diminished breath sounds, that oxygen's not going anywhere. It's just sitting in the lungs. And they have that diminished breath sounds, which is awfully the same as shallow, like shallow chest rise and fall, or you notice shallow respirations. It's the same thing, diminished breath sounds. Here's another one. 67-year-old presents a dyspnea and crackles lower lobes. What treatment would be the most beneficial for the patient? Again, what's the most beneficial? Sorry, my video is over it and I don't feel like moving it again, but the very bottom one, it says 5 centimeters of water pressure. You have 15 liters of oxygen via an arm breather, nebulized albuterol, positive pressure ventilation with BVM, CPAP at 5. So the thing that's going to be the most beneficial for a patient in potentially CHF is going to be D, CPAP. All the other ones are completely appropriate. They're going to be great for the patient. But again, the question is, what's the most beneficial for the patient? If all patients confused with pale, cool skin, rapid rate of 30, respiratory 30, radial pulses are weak and rapid, what's your highest priority? And it should be to rapidly transport to an appropriate facility. Pay attention to those test items where they're asking what your highest priority is. They're not asking what your next intervention is. They're not asking what the next thing you're going to do is. They're asking you, what is your highest priority? And your highest priority, they want you to know, is get them to a facility that can take care of them. So bright lights, cold steel, oxygen, diesel fuel, get them the heck out of there. All the other stuff is completely appropriate. But for this being a priority level question, C is going to be the most valuable answer for that patient. I think this is the last one on this one. 21-year-old MVC patient presents with guarding, lower abdominal bruising. BP is 94/60, heart rate of 130, respiratory rate 26. What should you suspect? And the answers are crazy. I like pelvic fracture with retroperitoneal bleeding. I just kind of put that there. Kidney laceration, cardiac tamponade, ruptured diaphragm with herniation, and A was hollow organ injury with hemorrhage. That's the only one that makes the most sense because he's guarding. He does have bruising in the lower abdomen. Any sort of abdominal bruising, you're going to end up with hollow organ injuries, especially if you are looking at low BPs, high heart rates. He is in some sort of compensated shock, potentially hemorrhagic in nature. Oh, apparently I have one more. Oh, this is the one. Yeah. This is probably the most challenging one. This is a 50-year-old with severe chest pain, lightheadedness for the past 2 hours. Symptoms began while exercising and has not been relieved with stress. What conditions are most likely causing the patient's presentation? Choose 2 answers that are correct. Now, this is not something you would see on the EMT exam. I actually stole this from the National Registry website. So you can actually go to nremt.org and you can actually look at the exam information. They actually have this. This is available to the public, so I'm just going over it. This is not an EMT level question. This is more of an advanced EMT and a paramedic level question, but I still like it because it makes you think. So to me, MI is going to be obvious. Like, well, yeah, he's having some chest pain. The other one is not going to be as obvious. Like acute pericarditis, not really likely. It could be an issue that he's had, but acute pericarditis doesn't suddenly come on within the last 2 hours. Exercise-induced asthma doesn't make a whole lot of sense because there's nothing to indicate that he's wheezing. You would think that makes sense, spontaneous pneumothorax. You're like, oh, wow, that, he's exercising, he's having chest pain. And it's not, I meant to put not relieved with rest, not stress. Has not relieved with rest. But really, the risk factors shouldn't really be in there because spontaneous pneumothorax we generally see in younger male populations that are taller. So the other one that pops out to me is PE, pulmonary embolism. He's within the risk category of it. He's having that severe chest pain and the lightheadedness that typically accompanies a PE. So I would actually put B and C. Although they didn't put the answers on the registry website, that's what I would put down. I don't know if I would have re-earned my National Registry license or not with that. All right. So after going through those questions, you might be like questioning yourself, and you're like, "Are you okay?" And this is the point in the test where, if you're taking the EMT or the paramedic exam, it's a computer adaptive test, so it's non-linear. So you'll have anywhere between 72, 120 questions, something like that. They'll cut you off as soon as they see that you're becoming competent, and at this point, you're probably getting exhausted, and there's a good reason for it. Your answers, by the way, are final. Again, I put my video over it, but there is no going back. As soon as you click it and press submit, you are on to the next test item, which brings me to another point. Each test item should be treated like a test in and of itself. So don't connect the dots from one test item to another and think, oh, they just asked this 2 questions ago. It must be connected to that. It's not. It's completely irrelevant. It's completely irrelevant. The way that National Registry does this is they actually have a cut score, and I don't want to go too nerdy into the cut scoring, but this does have implications on how you feel about the test. So as you get test answers correct, you'll get more and more green check marks. They'll go up, up, and up, and then start getting harder and harder and harder. As you get them wrong, it'll start going back down in difficulty and then going right back up and down and up, down and up. The cut scoring method allows them to be able to predict with great specificity. I'm never good at that word. Your ability to be competent at particular subject matter. So they can ask you fewer questions, and they know that you're probably going to do really well on this. So what does it got to do with your feeling? If you walk out of that test and you're like, that really wasn't too bad, I actually felt like it was pretty easy, that's a strong indication that one of 2 things. 1, you are stupid smart and you killed it and you really knew your stuff, or 2, you might not have passed. That's just what I've felt over the years whenever I've been teaching. If you walk out and you're like, that's one of the hardest tests I've ever taken in my life, I'm regretting my decision of being in medicine entirely, I may go do something else. There's a good chance you might have passed it. Again, you can't just go off that alone, but I'm saying that's a strong indication. If they have to give you really hard test items, that's a major problem. That's a good prop to you, because that means that you are probably banging on all cylinders. So the items should feel hard. The thing with the registry, and this is kind of what I'll close with, is you just kind of have to roll with the punches. You can prepare for it all you want. In class tests, your instructors, if they're any count, they're going to be giving you good test items, and I'm sure we have a lot of good instructors out there. They should be testing you frequently. You should be taking them seriously. Any quiz that you have, any test that you have, there's plenty of apps and stuff. I would say don't absent-mindedly flip through the many applications there are out there. There's test prep stuff. Be intentional about the focus. Be intentional about how you're actually learning this information and applying it and testing yourself, because that's the bigger key. Is you do not want to just accidentally pass the registry. It's not going to happen. You have to go with intention. So if you're going to have a test prep app, if you're going to do any of this stuff, sit down, make the time. Don't do it flippantly. Don't do it every, just for 5 minutes at a time and go on. Evaluate where you are. If your program has exams, see if you can look over those exams, analyze where you missed and what you missed and why you missed. If they do FISDAP, I know FISDAP does a print off. I think EMS testing does the same thing. I think LC Ready has some like that. But take a legitimate test, see exactly where your weaknesses are, work on those weaknesses for days or weeks, or depending on what your timeline is, and then retake the test and see exactly how you did. So there's a lot to the registry. I know it's a scary thing. I know it's bothersome and stuff, but I'm telling you, at the end of the day, it's a really good test. It does test your mettle. I don't think that everybody who passes the test needs to be out in the field, and I also don't think that everybody who fails it shouldn't. I do think, though, it is a mark of achievement to be able to pass that test and become one of us. So I hope you get to do the same.